So, dah cukup ke? Cukup dah?
Belum ke?
Nampak lah.
Boleh start dulu.
Dia start tu?
Boleh doktor start.
3 orang.
Start dulu. Okay, start lah. Ya, kita mula dengan kitab tu. Lepas tu.
Okay, Assalamualaikum warahmatullahi wabarakatuh. A very good morning. I will to Dr. Alwi and my fellow friends. So this morning, our group is going to present a teaching seminar 5 on this topic regarding growth disorder, IEM, and also sepsis and septic shock. So I'm the first presenter. So my name is Helmi. So I'm going to explain about the growth disorder, which involves the short and the tall stature. So here is my content, which I will explain later in the slides. So next. So first, we look at the growth phases in a person. So there are 4 phases. Growing up, there is the fetal phase, infantile, childhood, and so pubertal. So to explain a bit about each of these phase, is the fetal, the fastest phase, and the rate of growth. The growth rate is more than 30% of the eventual height, and in infantile there is rapid growth, which is the growth rate is decelerating at the rate of 15%. And in childhood, the growth is slow and steady, and the height during this phase make the 40% of a person's final height. And last but not least is the pubertal phase, which is influenced by sex hormones and adds around 15% to the final height of a person. So next, we look at this graph. This graph basically explain further about each of these phases that I mentioned earlier. So you can see each of these phases is can be influenced by different causes, like in fetal. So normal growth in this phase can be influenced by like the uterine environment, and in infant and childhood it can be changed with good health and happiness, because in certain cases, like you have deprivation dwarfism, which is when the child is unhappy and so on, then they will have reduced in secretion of growth hormone, and also problem with their nutrition, which cause them to become short. And then you can see the last phase is pubertal phase, which is influenced by the sex hormones, testosterone and estrogen. And here in this graph, it explains why in the lastly, why male is taller than female is because their childhood phase is longer, and they have more time to grow. Okay, next. Alright. So we look at the average height velocity for each of these phase. So
Sorry. Sekejap
alright. Okay. Can we resume?
Yes. Nampak ke?
Boleh enlarge sikit, zoom sikit tak?
Yep.
Right. Here we can see the average height velocity. This is based on PITS protocol under the endocrine section. So in the first chapter, there is an approach to child with short stature. So you can see in each phases there is the rate of growth is different for each phase in a child. So you can check the rate of growth for each phase. And then below that is the important formula that we need to remember, which is the mid parental height, which is important um, to estimate the child's supposed height, but in relative to their parents. So for boys, we need to add up the father's height and mother's height plus 13 and then divided by 2 as for girls, it need to be subtracted by 13 and then divided by 2. Okay, next slide. Okay, this just how we measure height in pediatric patient. So for patient less than 2 years, we use the infantometer, as you can see on the first picture on the right of the child with pink shirt. So this measurement of height using this method, you need to have the feet in perpendicular to the lower legs, and then the head must be held by someone to assist this procedure to assist in measuring the height of the child. As for children more than 2 years, we use the half-pendant stadiometer, which is on the smaller picture on the right side, in which the child needs to be standing barefooted, and then in certain cases, the height of the child may be reduced by 1.25, and this may be the cause of referral, which may be falsely referred for problems in while the cause is basically just the instrument itself. Okay, next. Okay, because this is related to growth disorder, so this is just a recap on the physiology on the regulations of the growth hormone. So basically, the hypothalamus will secrete either growth hormone releasing hormone or growth hormone inhibitory hormone, which is also called as somatostatin. So this will stimulate the anterior pituitary, which secretes growth hormone as well as other hormone like thyroid stimulating, ACTH, LH, FSH. And then this growth hormone have indirect or direct action for the growth in the child. So some of the indirect action is it acts on the liver and other tissues. So in the liver, there will be production of this insulin-like growth factor, which is called IGF, or to be specific, IGF-1, and then it affects on the skeletal and also extra skeletal of the child. And then, as you know, in this physiology, there need to be a negative feedback in which the IGF will send negative feedback as well as the growth hormone if there is excess of this hormone. And then growth hormone is also secreted in the pulsatile manner. So, yeah, all right. Next slide. So we look at the definition of the child with short stature. So basically, we call a child as short stature when his or her height is below the third percentile, which is less than 2 standard deviation for a child's age and gender, or height is significantly below the genetic potential, which is less than 2 standard deviation below the mid parental target, or if the child has an abnormally slow growth velocity, and when we put on the growth chart, there is a downwardly crossing percentile channel for child more than 18 months of age. Okay, next slide. So here are the causes, some of the causes for in child with short stature. So there are variations of normal, which are basically the constitutional short stature or genetic short stature. And then we have endocrine problems like hypopituitarism and also growth hormone deficiency, syndromic causes like Down syndrome, Turner syndrome, skeletal dysplasia, and also systemic chronic disease, which basically affects the nutrition of the child, and then they have loss of appetite and so on, which affect the nutrition and then affects the growth and the stature of the child. Okay, next slide. So here is a comparison between the familial and constitutional short stature. So we can see basically the difference is in familial short stature, there is a history of short stature in the family, which is the parents, either one or both of the parents. And then compared to constitutional short stature, the parent's stature is this average or is normal. And then as you can see on for each of the rows for the familial short stature, everything is normal except until the pubertal growth where the rate is low to the normal. And then final adult height in familial short stature will be short, which will be similar to the parent. However, in constitutional short stature, there is a bone, if you call bone age is delayed, and then puberty in this patient is also delayed. However, the final height or final adult height in this child will be normal, similar to the parents. Okay, next slide. So here you can see a growth chart difference between a child that have familial short stature and also constitutional short stature. So the graph on the left, the growth chart on the left showed what we call familial short stature, in which there is consistent in the height. The height of the child is consistent throughout the years, and also below the third centile. However, in constitutional short stature, you can see a during puberty stage, it will be delayed, and then after puberty, the height will pick up, and then be in the normal range. Okay, next slide. So for measurement of bone age, we refer to this atlas of Grulich and file, in which during investigation we did AP radiograph of the child's left hand and wrist, and then we compare it to this atlas of Grulich and file, and then see if there is any delay of the bone age. Okay, next slide. Okay, just now I mentioned other causes, basically, which is the variations of normal. Now we go into the other causes which are involving the endocrine. So first we look into growth hormone deficiency. So growth hormone deficiency can be caused by either a congenital or acquired, like in tumor, and then the presentation is usually the child will have severe growth failure, the bone age is delayed, as well as the weight and height ratio is increased. So investigations that can be done in patients with growth hormone deficiency is, of course, we need to measure the growth hormone level, and then measure the IGF factor 1 and also IGF factor binding protein 3, which is both of these IGF-1 and IGF-BP3 is made in the liver, and also we take X-ray of the hand and wrist, as I mentioned just now, and check the bone age. Alright. So next slide. This next we'll go into Cushing syndrome, which also falls under the endocrine causes of short stature. So as we know, Cushing syndrome is caused by excessive cortisol secretion, and then this causes the child to have an increase in weight and growth retardation. So in Cushing syndrome, we know that the patient have central or truncal obesity, and then short stature. So this is disproportionate or excessive weight for height. So the causes can be either ACTH secreting pituitary adenoma or adrenal adenoma, which is ACTH independent, does not depends on ACTH secretion or stimulation. And for diagnosis of Cushing syndrome, we can use collection of 24-hour urine cortisol or low dexamethasone suppression test. Okay, next slide. So we look into the syndromic causes of short stature, which is the first. We touch a bit about Turner syndrome, which is absence of one set of genes from the short arm of one X chromosome. Basically, it's missing another X chromosome, which causes to have the 45XO. So as you can see the picture, the features seen in a child with Turner syndrome, for example, like rudimentary ovaries, and also the patient does not have menstruation or achieve menarche, and then as well as involvement of the heart problem like coarctation of aorta, and also other signs that you can see on physical examination. Okay, next slide. So this is another syndromic causes, which is, I think everyone is familiar, which is Down syndrome. So it's caused by trisomy 21, which affect the physical and mental state of the patient, and the patient can have also disability. So physical features, as you can see, the patient will have short stature, mental disability, hypotonia, flat nasal bridge, and also single palmar crease. So the picture on the right side further explains about these features of Down syndrome. Like as you can see, the child have a flattened nose, upward slanting of the eyes, and then on the foot we can see there is sandal gap between the first and the second toes, single palmar crease, and also clinodactyly, which is the inward curving of the fifth digit. Next slide. So we go into Prader Willi syndrome. This basically caused by chromosome 15 deletion. So this is basically what Dr. Ismail taught me back when he's still in UIA. So in child with Prader Willi syndrome, there is 2 hypo and 2 hyper that we need to remember, which is hypotonia, hypogonadism, hyperphagia, and also hyperglycemia. And on the right picture is we can see the syndromic faces in the child with Prader Willi syndrome, like almond-shaped eyes, thin upper lip, and also narrow distance between temple and also nasal bridge. So just to explain a bit about this, why this patient was presented with Prader Willi syndrome. With these features is because adverse they will in the early infant they will have hypotonia, and then they will have problem with feeding, problem with sucking reflex, and cause them to be less in weight, decrease in weight, and then as time goes, they reach to childhood phase. So there will be the tone will be better, and then not the tone will be better. There will be reflex because in early stage of life they will have poor feeding, and then in the next phase of their life they will become hyperphagia and eat more as compared to the earlier phase of their life, and then they will be at risk for getting diabetes mellitus or hyperglycemia. Okay, next slide. And then this is the Noonan syndrome, which is an autosomal dominant. And then it is usually associated with pulmonary stenosis. And you can see on the picture that few features that is significant in Noonan syndrome, like skin webbing, and then practice sternal deformity, widely spaced nipple, and also inverted triangle shaped head. Alright, next slide. Okay, then we go to Achondroplasia, which is caused autosomal dominant cause. Is in this child there is mutation in the FGFR3 gene, and then the features involve disproportionate dwarfism, which is the limbs will be shorter compared to the trunk, and then shortening of the proximal limbs, and as well as microcephaly in relative to the dwarfism. Alright, okay, next slide. Okay, so evaluation of children with short stature, basically when we suspect the child have a short stature, so most important thing is we get a complete history, and we also do physical examination. And then on physical examination, if there is any dysmorphic features, either yes or no, then we can narrow down to what causes the patient to have short stature. So if the patient have no dysmorphic features, then we might need to think about other causes aside from this syndromic causes, as I mentioned earlier. Maybe we can think about endocrine causes, we can think about variations of normal, or maybe malignancy and so on. Okay, next slide. Okay, this what we need to know in history taking. Basically, antenatal history, we know and if there is any complication during pregnancy, maternal smoking, or high risk behavior, or infection. And then from birth history, we know the gestational age, first weight and length, the Apgar score, and there is any neonatal complication. Also, we need to ask about the developmental milestone, dietary history of the child, any previous medical history, family history. This is with respect of familial short stature, we need to ask about the family history of short stature for 3 generations. And then also the age of onset of puberty in the family members of the same sex. Any any medical illness in the family, social history is also important. As I mentioned earlier about how the happiness of the child affect their growth. So we need to ask about if they acquire or ask and child abuse, the relationship between mother and child, also if there's any emotional deprivation. Next slide. So for physical examination, we look for general appearance, dysmorphic features, as I mentioned earlier in the syndromic causes. And then nutritional status of the child. And then we look at the anthropometric measurement, which is the height, the weight, the head circumference, arm span, which is more important in the child with tall stature, like in Marfan or Klinefelter. And then the upper and lower segment ratio. And then last but not least is we need to do the pubertal staging, which is based on the Tanner staging. Okay, next slide. So the arm span, as you can see in the picture on the left side, this is the how we measure the arm span. And then on the right picture is different the upper segment and the lower segment, which is divided or separated by the pubic symphysis. So why the upper and lower segment discrepancy is important is because there is increase in upper to lower segment ratio. It can be related to untreated hypothyroidism. And if there is a decrease in upper to lower limb ratio, it can be related to hypogonadism. Okay, next slide. So there are a few investigations that we can send in child that we suspect with short stature. General tests like full blood count, renal profile, liver function test, and so on. And then we can send for chromosomal analysis. For child with, for example, like Down syndrome. And then endocrine tests like thyroid function test. And then the growth factors, which I mentioned earlier, IGF-1, insulin-like growth factor 1. And also IGF-BP3. Also, we can do the growth hormone stimulation test. And then for imaging, bone age is important, as well as CT or MRI brain, which we suspect that is tumor or lesion in the pituitary that affect the growth hormone secretion. And then other investigation that is also important, like arterial blood gas and also radiograph of the spine. Okay, next slide. So approach in child with short stature is you can see the chronological age is the actual age of the child. The height age is the age at which this current height of the child lies on the 50th centile, and the bone age is the age of the left hand and the wrist after X-ray. So in familial short stature, we can remember by the height age will be lesser compared to the chronological age, which the chronological age is equal to the bone age. And then the constitutional growth delay is basically the bone age is lesser than chronological age. For example, if the child is currently like 8 or 9 years old, the bone age is earlier than that. The bone age is like maybe 6 or 5, and the bone age is equal to the height age. And then as for the pathological short stature is the bone age is lesser than the height age, and the height age is lesser than the chronological age. Alright, next slide. So for management, basically we treat the underlying causes, and then we need lifelong psychological support as well as growth hormone medication. So these are the indications for growth hormone treatment. So we give growth hormone in patient with growth hormone deficiency, the congenital or acquired, and then for example, Turner syndrome, Prader Willi, and also in idiopathic short stature. So growth hormone treatment is we give somatropin, which is daily at night, and we usually start with low dose, and then we alter it depend on the clinical response, the side effect of the medication, and also the growth factor level, which is the IGF-1 and also IGF-BP3. After that, we need to monitor this patient every 3 months. And when to stop this medication is when the child is reaching the final height and the height velocity is appropriate, which is less than 2 cm per year over at least 9 months. And then for girls, the bone age is more than 13 years old, and for boys is more than 14 years old. Okay, next. So finish with short stature. So next we go to the tall stature. So in child with tall stature, the height will be above the 97th percentile for the age and the sex, or more than 2 standard deviations.
Sorry.
Yes.
Syah, try to simplify sikit I mean try to simplify a bit your presentation. Ni last kan? So stature last kan?
Yes. Last.
Oh, okay.
Okay. So that is the definition of the tall stature, and this is, however, an uncommon complaint lah. Okay. Next slide. So these are the etiology of the tall stature. Basically, can be caused fetal overgrowth, and then non-endocrine and endocrine cause. And then next slide. So familial tall stature is the most common cause, and then this also is a variant of a normal growth. And in this patient with this familial tall stature, no underlying pathological cause. And then in this child, we need to measure the mid parental height, and then look for these clues to suggest familial causes, which is there is a family history of someone with a tall stature, no dysmorphic features, height velocity is between high to normal range, and the bone age is normal. Next is the excess growth hormone secretion. So in young people with open epiphysis, it can lead to gigantism, and with closed epiphysis, it can lead to acromegaly. So the cause of excess GH secretion may be due to pituitary adenoma, which is more common in male and may cause hyperprolactinemia with keratoria as a presentation, and also may compromise other anterior pituitary function. And then we look for the features of gigantism, like there is longitudinal growth acceleration, large hand and feet. Facial features become coarse and also rapid growth of the head, as you can see on the picture on the right side. Okay, next. Next we look into the Klinefelter syndrome, which is the patient will have gene of 47XXY, male. So he will have a tall stature and slim, long legs compared to their trunk, and then learning difficulties. And then you can see the pictures of the Klinefelter syndrome on the picture they provided. For example, like small testes, gynecomastia, and so on. Okay, next slide. So next is Marfan, which is autosomal dominant abnormality of the connective tissue. So this is one of the reasons why we need to do the arm span. So in Marfan syndrome, the arm span to the height ratio will be more than 1.05. And then here are the few signs that we can see on physical examination, like Steinberg sign and Walker-Murdoch sign. And it's also associated with heart problem like aortic or mitral regurg, and also scoliosis. Okay, next slide. So this is Soto syndrome, or what we call as cerebral gigantism, in which the height will be above the 90th centile. For the weight and the height will be above the 19th centile at birth. Presented with enlarged head, and this is caused by mutation in the NSD1 gene. And the main features involve microcephaly, the forehead and jaw become prominent, high arch palate, and also hands and feet will be large with thickened subcutaneous tissue. Right, next slide. So investigation for those with tall stature is we need to do karyotyping in patient with suspect Klinefelter or Klinefelter or Marfan, and then we send for thyroid function test, which the TSH and T4 level will be increased, IGF-1, which will be increased in acromegaly and gigantism, as well as we assess the bone age, and then we measure other hormones level like LH, FSH, testosterone, serum cortisol prolactin, as well as we do the glucose suppression test for the growth hormone in patient that we suspect with acromegaly. Next. So for management, in pituitary gigantism, which is there will be excess of growth hormone secretion. So as you remember in the physiology I mentioned earlier too, the growth hormone is released in pulsatile manner. So the one that inhibit is called somatostatin. So due to GH excess, so we can use somatostatin analog, which is called octreotide, to suppress the GH production. However, this medication has significant GI side effects. And then other medication that we can consider is like Visoman, which compete with the endogenous growth hormone to bind to the growth hormone receptor. And this medication also suppress production of the growth hormone. Otherwise, we can also give hydrosteroid to promote epiphyseal closure. Alright, next. Okay, I think that's all for my presentation. Sorry if I take a bit of your time. Is there any question?
Okay, so ada any questions, guys? Okay, so that's very good presentations, very detailed, a bit lengthy though. But so basically, what to say? In general, you guys are adults, kan? You guys are adults, and we are doing in adults learning. The learning is actually initiated. It may initiated by the teachers, by the instructors, but it has to be maintained and has to be flourished by the student lah. Okay, so the principle of presentation of the seminar, I'm not sure about in the past lah, but in general, the aim of the seminar is actually to give you guys the outline, okay, what you guys need to know and what should be included in the topic. Okay, it's not meant to actually to teach the detail or the A to Z of the topic, but rather an introduction, and to be, to be used as a framework for you guys to work on, to establish your knowledge lah on the topic. So actually kan, seminar don't have to be too long tau. You know, the seminar, it don't have to be too long. The slides not to be too extensive. What you just need to put in the slides is actually what is important. Okay, what you think is important. Okay, and then we can discuss later. I mean, in the class, what is actually important from our perspective as a instructor, and also you guys as a student. And then besides that, I would love to see in the slides things that cannot be obtained from textbooks. Something extra that is important, or more important, or similarly important than those information that you get from textbooks. Because textbooks you guys can read textbook, and you guys can read textbook and can access to the website. I mean the textbook online kan. Tapi things that you guys, things that we tend not to search on, or search for. These are the things that we have to introduce in the seminar. Okay, rather than we discuss detail on like the causes of short stature, and you describe the disease, is good, but it takes a lot of time, and I don't think you can actually compare. You may be able to compare some, but I don't think you can actually recall or can actually memorize all what the presenter been presenting. Rather than presentation, the presenter should just give an overview, and then give an outline, and also provide a framework, learning framework for others. Later on, after the class, you guys can read upon that topic, and that can become like your boundaries. Not to go beyond it, or not to go less than it. Faham tak? Because if not kan, seminar, I realize seminar is a bit boring tau, macam lecture. I'm not sure about you guys, I hate lectures. Okay? The way I learn in my undergraduates is totally different than you guys lah. Because I'm totally PBL. I learn PBL, problem-based learning. So we learn by problem. We don't have lectures. In a week, I just got like 2-3 lectures, 2-3 hours of lectures in a week. In fact, by 5th year, we only got 2 lectures, 2 hours of lectures per week. And the rest is actually clinical, and then we learn from cases lah. And I think that is more interesting, and it triggers you to think and apply your knowledge, rather than like parrot, just memorize and you just but later on during application it'll be difficult lah. Tapi it's okay. It's my fault juga. So I didn't set the rule from beginning. But it's okay. Anyway, the presentation is very good. It's very detailed. Cuma there are a few things that you have to remember. Okay, why do we need to learn about the short stature? Why is it so important? Because you know, short stature is not like most of the time lah, the causes of short stature and the complication of short stature. It is not like ada life-threatening disease or life-limiting disease macam contoh macam you know cancer ke oncology or asthma even. Tapi kenapa you nak kena belajar short stature? Why short stature has to be included in your curriculum? And why do you need to learn short stature? Faham tak? That things that is more important because once you know the importance of something, then you'll appreciate more. Faham tak? And I'm start to babbling now, but because if you don't know the importance or if you don't bother to know the importance, then you won't appreciate and it won't last in your brain. For example, kan, I give you an example lah. Last week I was talking to my wife. We were discussing about something lah, and then we are talking about nail clipper tau. And then I asked her, we are comparing like nail clipper and something lah, I can't remember. And then I asked her, so what level of takal, what level of tuas is that? It's nail clipper. You guys know what tuas is? Tuas tahu kan? I tak tahu you belajar bahasa Inggeris semua, but I learn bahasa Melayu during my primary school, bahasa Melayu, science is in Malay. So you tahu what tuas? Tuas, takal, all the simple machine. Anyone?
Is that
Kau dengar tak tuas?
tahu tu?
Level
Pulley, yes. Pulley. I think in English
Level.
it's called pulley. Level or pulley. Pulley, I can't remember lah. I don't know bahasa Inggeris. Tapi I learn in Malay lah. So you can tahu ada level 1, level 2, level 3 kan. It depends on where the force is, where the way is, where the force kan. Whether is it in the center fulcrum, is it in the center or at the end. So basically kan, because I know, I think this is very important when I learn this. So I still can remember the things and the principle and also the application of this. But my wife said she can't even remember anything about that. So when you know that, when you appreciate the importance of the things of something, you'll remember better, and you'll be able to apply it. So that's the gist lah. So in our education, in our teaching, the most important is to realize the importance of the thing that we're learning and to know why we are learning this. So kalau I tanya Shah kan, okay Shah, why do we need to know about short stature? Is it just simply because later nanti orang akan refer to you short stature? So short stature, kenapa you kena treat? Because 90% of short stature, actually 70 to 80% of short stature is actually CDGP, constitutional in origin, or genetic short stature. You rarely come across yang tumor or hormonal problem. Even if hormonal problem, you tak treat pun it's okay je. Dia short lah. Tapi people live with it. Faham tak? So kenapa kita kena belajar pasal short stature? Syah.
I think because short stature also relate to the psychological or confidence in the child.
Okay, yes, that's very
Not
true.
treated
Good. Again.
If not treated can cause psychological problem. And then I think to look for other complication associated dengan short stature,
such as
like in certain thing like in Down syndrome, it can related to the heart problem. And
tapi itu Down
hypothyroid.
syndrome. Dan kalau you miss Down syndrome, you don't diagnose Down syndrome incidental finding for referral for short stature. That's very bad, you know. Kan? You diagnose Down syndrome first, then only short stature because you know they got short stature. Tapi you tak dapat referral for short stature, tapi dia rupanya Down syndrome. That's so bad.
Okay, sure.
And so again lah, you correctly mention. So you have to mention lah the importance of identifying and also managing the short stature. First, the psychological implication lah, bully, depression. These are commonly associated with short stature. And then you have to look at bigger picture. Okay. Okay, I suggest you guys, okay, balik ni, you search dekat Google, okay, search to at Google. Kalau you rajin pergi World Bank punya website, okay, and then ataupun you Google cakap the cost of short stature. You baca cost of short stature, COST, cost of short stature, and then you baca on that. Baca the articles, even there's a report. There's a lot of report on short stature because you know the world are fighting short stature. You know? Just similarly, we are fighting the poverty. We are fighting short stature and stunted. Okay, and then you have to differentiate between short stature and stunted. You cannot say someone yang, contoh you got a child yang baru 1 year old, datang dekat you plot growth chart, dia pendek. Then you cannot say that is short stature. That is stunted. Okay, because you have to understand the growth, the graph. Cuba buka graph tadi, graph yang growth yang height ni, yang height contribution tu. Atas, the first few graph tu. I think second slide, third slide. Mana graph tu? Bukan tu, yang the growth tu, yang daripada in utero, infantile. This one. Okay. Look at this kan. Can you zoom it? So I'm very into short stature lah. Because my interest is endocrine and particularly short stature. So look at the graph. Okay. Okay, you look at the infant. Okay. Infant is only 1 year. Remember, infant is only 1 year and it contributes 15% of adult height. So your final height, 15% of your final height is contributed by the first 1 year of life, 1 to 3 years of life. Usually 1 to 2 years of life. That is the period of your life that will contribute the most to your height. Okay. And what actually affect that? What are the factors that contribute to the length or to the height during the infancy? It's nutrition kan. In fact, throughout your growth, the only phase yang nutrition play a role is during infancy. Cuba you tengok the graph. Childhood, there's no mention of nutrition. Pubertal, no mention of nutrition. Fetal, definitely is maternal nutrition lah. So, if you fail to tackle during infancy, the only period yang you boleh interfere you boleh interfere with the final height is actually during infancy. That's the only period. The first 1 year of life. That's where you want to catch them. Faham tak? So, kalau contoh lah, budak datang dengan you, referral datang you umur 5 tahun, short stature. What can you do? There's nothing much can you do. In fact, there's nothing you can do. You can only investigate for pathological, but 99% of time you will diagnose, okay, your child is short stature. Because it's too late because of your nutrition. Because during infancy, your nutrition. 99% of time, that's the diagnosis. Faham tak? So when you learn this topic, at the end of this topic kan, what I want you guys to bring back is the importance of monitoring growth during the first 1 year of life. Because that's the only way you can interfere. Faham tak? Kalau you talk about syndrome, all this genetic, and all these causes, CGGP, these are non-modifiable tau. These are non-modifiable problem. The only things that you can modify is nutrition the first 1 year of life. Okay, remember So, and you don't call them short stature. So those yang 1-2 years of life come to you with short stature, you don't call it short stature, you call it stunted. Short stature is a diagnosis after the period of infancy. Because when you say short stature, then you know there's nothing you can do. Once you label a child short stature, you know there's nothing you can do except in about 1 to 2% of the cases where it is caused by growth hormone deficient. But the rest, there's nothing you can do. Almost nothing lah. Kalau macam trainer, you boleh bagi growth hormone. Okay, faham kan? That's why this slide is very important. This slide is very, very, very important. So, balik ni, I want you to ponder on this slide, especially this particular slide. And then you read you just Google cause of short stature or cause of stunted. And then you read about it. It's very amazing and it's very worrying, you know. It's very worrying. Okay, that's all. Ada soalan? Ada soalan? The rest ni just to monitor and to diagnose. Which again, so once you diagnose, it's too late lah. Once you diagnose short stature, then it's too late. So you are not supposed to diagnose short stature. Prevention is better than cure lah, because this disease has no cure. Contoh lah, kalau contoh you catch a child with growth hormone deficiency. So apa yang you boleh offer? The practical things, you guys 5th year kan? Kan 5th year kan? No? Guys, you guys 5th year kan?
Doctor, 5th year.
Yes.
So the other thing is the practicality of your treatment lah, because we don't offer growth hormone to anyone, no? They have to pay. It's very expensive. It's very expensive, and then patient have to pay for the growth hormone, and it's not easy. It's more difficult than insulin because it has to be given subcutaneous daily. So you need a machine attached to the child. It's not simple lah. It's not simple. So the practicality, most of the time, 99.999% of the children that we diagnose with growth hormone deficient, they end up cannot afford growth hormone pun. So they end up short lah. Okay, so next presentation. Thank you.
Alright. Zahra, it's okay, I can present it. Oh, Zahra?
Yes, yeah.
Okay. It's okay. Alright. So my part. Zahra, can you start sharing the slide?
Oh, okay.
Okay, so so my part will be Zahra je lah present. Sorry, rapat. Okay, so my part will be inborn error metabolism. So let's make it simple as what doctor have mentioned before. Okay, next slide. So before we proceed, we have to know what is IEM. So IEM inborn error metabolism. It is a group of genetic defects that affect the metabolic pathway in our body. So the defect may cause abnormality in terms of quantity or quality of the substance being expressed by the gene, which subsequently will disrupt the metabolic pathway. As you can see in the diagram on your right, that is the overview of the pathophysiology that happen in IEM, where, for example, there is a defect at the pathway from B to convert into C and D. So when there is defect at B, at the pathway B to C, there will be no substance, substance B will be not converted into C and D. So C and D will be less. And then substance B will be excessive in our body. This accumulation of substance B will then form alternative way to form other substance such as substance E. In inborn error metabolism, this substance E that will cause the disorder in this disease. So most IEM, they are being transmitted by autosomal recessive, where the affected child is inherited two defective genes from each parent. So some also may inherited through X-linked transmission. Right, next. So why we have to know inborn error metabolism? Even though it's a rare disease, but it's there. So that's why we have to learn inborn error metabolism. Overall incidence in worldwide is around 1 in 4,000 live births. And there are 400 types of inborn error metabolism that are being identified before. So some of the common IEM in Malaysia is they include G6PD, maple syrup urine disease, PKU, and also urea cycle defects. Okay, next. So we're going to look at some of the classification of IEM. So basically, IEM, we can classify into two classifications. First one is according to metabolism. So in this table, it shows that the classification of inborn error metabolism according to its metabolism. For example, disorder in amino acid metabolism, the diseases such as PKU, alkaptonuria, and homocystinuria. Disorder in carbohydrate metabolism, such as galactosemia, glycogen storage disease, and also, you can read the classification after this. Next, so this table is the classification from our PITS protocol, where this classification is more relevant. It is from a therapeutic perspective, where inborn error metabolism can be divided into 5 major groups. So group 1 is the disorder that give rise to acute or chronic intoxications, such as the disease such as amino acidopathies, such as MSUD, and others. Second group is disorder with reduced fasting tolerance. Next table. Third group is disorder that neurotransmitter defects and related disorder. Group 4 is disorder of biosynthesis and breakdown of complex molecule. And group 5 is mitochondrial disorder. Group 1 and group 2, in the table before, they are the ones that we have to diagnose early, because most of them have appropriate treatment, and also they can be diagnosed quite easily as compared to other group. And also, another information that group 1 and group 2 is relatively more common as compared to group 3, 4, and 5. Okay, next. Right, so approach to IEM. Next. So when who should we suspect for inborn error metabolism? So of course, clinical suspicion should be it should be considered in any acutely ill child. And however, the presentation of IEM is not specific. That's why we have to consider this IEM as a differential diagnosis, not as a provisional diagnosis. So because the presentation mimics other diagnoses such as the IEM, they mimic other conditions such as sepsis condition. And the clinical presentation mostly that are presented in IEM, which are poor feeding, vomiting, lethargy, convulsion. Specifically, they are not responding to D10 solution, B6 or calcium, and eventually this the infant also can be presented in a comatose state, and patient also can have poor tone, mostly hypotonia, but special in MSUD, that is hypertonic state. So another additional clues to help us in diagnosing IEM is concerned genetic history. For example, marriage among cousins and a clinical deterioration after feeding, which means prenatally and postnatally the infant is well, but once they start to fade and then the body start to metabolize, then this problem will appear. And then another presentation is acute encephalopathy preceded by fever or vomiting, and then unexplained metabolic acidosis or hypoglycemia, where there is metabolic acidosis and hypoglycemia are some of manifestation in IEM. Then history of unexplained sibling neonatal death, because this might be the sibling might have IEM, but they are being undiagnosed. Then maternal history of House syndrome and also unusual smell or sweaty feet. All right, next. So this is algorithm for to approach IEM. So first one is when you find the initial finding include one or more of the following. First one is poor feeding, vomiting, not due to GI anomalies, lethargy, convulsion, and also coma. So it is important that you have to rule out first infection, trauma, or CNS anomalies, because their presentation is quite the same. So once you infection, trauma, and CNS anomaly is less likely, then you can suspect for metabolic disorder. So first thing that you have to obtain is plasma ammonia, because most IEM disease, they have what we call that, hyperammonemia, high ammonia in their blood. So that's why we have to obtain plasma ammonia first. Then if it is high, then you have to obtain anion gap. So anion gap, the formula is potassium plus sodium minus chloride and bicarbonate ions. So if the iron gap value is normal in hyperammonemia, so urea cycle defects can be suspected. If both are high, hyperammonemia and also high iron gap, then organic acidemias can be suspected. On the other hand, if both value are normal, then amino acidopathy such as MST and PKU or galactosemia can be suspected. All right, next. So apart from plasma ammonia and also anion gap, that and then get tests that you take. You also need to take other basic metabolic investigations such as glucose, lactate, blood gases, and ketostate. And also you need to consider also some special metabolic investigations such as carnitine, which is will be high in fatty acid metabolism defect, and then amino acid, plasma or serum, organic acids, and also orotic if you suspect urinary cycle defects. Okay, next. So this one is table showing that the normal value that you have to remember, especially ammonia. So in units, value is less than 110 is health is considered normal value. Okay, and then you suspected IEM, the value usually more than 200 micromole per liter. Okay, next. Okay, this table also showing the value of the test that may help us towards the diagnosis. All right, next. Okay, so this one is initial management of sick child with suspected IEM. Even though the actual diagnosis is, we still do not know the actual diagnosis. Once we suspected the child with IEM, we should start the management as early as possible. Why? Because sometimes clinical deterioration is very rapid, very rapid. That fatality can occur even before investigation result came out. So that's why we need to initiate management as early as possible. So the first one is immediately stop protein intake, because we restrict the protein intake because of the defect at metabolism pathway, and then we correct hypoglycemia or metabolic acidosis with D10 solution. And next, we give adequate calories to this adequate calorie because we want to prevent catabolism. As we all know that when we want to produce energy, our body will metabolize carbohydrate first, right? Then fatty acid, then protein. So we want to prevent that from occur. So that's why we have to provide adequate calories to the suspected patient. And then anticipate complications such as if hypoglycemia, then you give intravenous insulin, fluid overload, intravenous furosemide, electrolyte imbalance, and protein malnutrition. You can give feeding by milk. And then carry out detoxifying measures. And after this, you can we will see what is detoxifying measures. And then continue supportive care. If patient is in respiratory insufficiency, then we have to ventilate the patient. If patient comes with convulsion, then we can we have to give anticonvulsion. And if cerebral edema, so we ask patient to avoid to restrict free intake and also mannitol. All right, next. Okay, next. Next, Zahra. So this step 2 is actually when we already know the specific diagnosis, which I will explain after this. Next, Zahra. So this one, specific detoxification measures in hyperammonemia. So remember that first thing that we take is plasma ammonia. So when there is high ammonia, then we can give anti-hyperammonemic drug cocktail. It is indicated when the ammonia level is more than 200 micromole, and also patient is symptomatic, which is encephalopathic patient. Then this drug cocktail contains of sodium benzoate, sodium phenylbutyrate, arginine, and it should be mixed together with the 10 solution in total volume of 50 ml, infused over 90 minutes. All right, next is dialysis, because we want to remove this toxic substance. Indication is ammonia is more than 400, symptomatic and inadequate reduction. Despite being, we already give the drug cocktail, but the ammonia is still high, then we consider dialysis. All right, next. So once we know specific diagnosis, so this one is specific detoxification measures for MSUD. Non-pharmacologically, we can offer dialysis. The indications like as you can see in the table. Important one is in organic acidurias is we can give carnitine, 100 milligram per kilo per day. All right, next. So next. Now we're gonna look at some importance inborn error metabolism that is important. The first one is amino acid hepatitis, where there is disorders in metabolisms of amino acid. The first one is phenylketonuria, PKU. So in this disease, there is phenylalanine hydroxylase enzyme deficiency, as you can see in the diagram on your right. There is phenylalanine hydroxylase deficiency where Zahra show. So when there is lack of that enzyme, phenylalanine cannot be converted into tyrosine, right? So this phenylalanine will then be accumulate in our body. So like I mentioned before, when there is excessive of phenylalanine, they will form alternative way where phenylalanine will be converted into phenylpyruvate. And then phenylpyruvate will be converted into phenylketone, which is phenylactic, and also phenylacetic. So this phenylactic and phenylacetic that cause the manifestation of abnormal urine order in PKU, right? Important point in PKU is that excessive plasma of phenylalanine, it saturates amino acid transporter in blood. It can travel into brain, causing blood-brain barrier at brain. They compete with tryptophan and tyrosine for amino acid transporter. So tryptophan and tyrosine, they kalah. Then which causing this patient with PKU will be less of neurotransmitter production, and eventually will cause mental retardation in PKU patient. All right, next. So the features, because of lack of neurotransmitter, patient will have intellectual disabilities, protein order urine from phenylketone substance, and vomiting, psychotic such as ADHD and ASD, also developmental delay. For screening, tender mass spectrometry, this one is not done in measure. So what in measure what we did is we take to diagnose PKU, we take serum phenylalanine. So when there is high, so we can suspect PKU. So management is phenylalanine low diet. Right. Next IEM is MSUD, maltose urine disease. So in this disease, it is what is lacking is branch of keto acid dehydrogenase enzyme deficiency, which cause of lack of catabolism of valine, leucine, and isoleucine. So there are 5 clinical phenotype, which is classical MSUD, where this is the most severe form, and intermediate MSUD, milder form of MSUD, intermittent, thiamine responsive MSUD and increased supplement deficiency. Right, next. So for clinical features, as other inborn error metabolism, then we have feeding, lethargy, conversion, coma, cerebral edema because of hyperammonemia that accumulate in the brain. And then especially in MSUD, while other inborn error metabolism, they have hypotonic state, but MSUD, they have hypertonic state, and death usually occur after a few weeks and also months if left untreated. So diagnosis is amino acid analysis, enzyme acid, neuroimaging. Treatment is supportive treatment, hydration, and dialysis to remove the excess toxic IV mannitol for cerebral edema and ensure adequate calorie intake. Okay. In MSUD, there are also in brain there will be also competition occur where in MSUD there will be also lack of neurotransmitter production. Okay, next. For urea cycle defects, next. If you remember this Krebs cycle, Krebs cycle, when there is deficiency of the enzyme in the blue box, hyperanemia type 1, which is carbamide phosphate synthetase deficiency, or OTC deficiency, succinic acid synthetase deficiency, arginine succinate acid lyase, and arginase deficiency. So this one is the presentation of urea cycle defect. So clinical features, units, then we have poor feeding, lethargy as usual, and vomiting, convulsion, and also poor tone, cerebral edema from hyperammonemia, and also in infants in older children, they will have mental confusion, and agitation, irritability, and also coma. Okay, next. For diagnosis, it's quite the same. We take serum ammonia, and then get plasma amino acid measurement, enzyme acid, and gene study. So this one is we already looked at the specific measure for hyperammonemia before. So remember, hyperammonemic drug cocktail and also dialysis. Right, next.
Guys, sorry, I kena stop kejap je. Dalam tak tahu ada 25 minutes. So maybe 5-10 minutes kejap. Kejap
Okay.
No?
Okay. Sementara tu korang ada soalan tak? Ataupun ada nak benda yang nak kena repeat ke?
Okay guys, sorry lah. Okay, sambung.
Okay, for organic acid. Boleh dengar?
Boleh.
Okay. So for organic acid, acidemia acidinopathy. So example of disease propionic acidemia. So in this disease, the enzyme that is deficient is propionyl CoA carboxylase enzyme. So when there is lack of this enzyme, then there will be lack of conversion of propionic acid to methylmalonic acid. So clinical features as others as well: poor feeding, lethargy, vomiting, convulsion, and coma, metabolic acidosis, which is special in propionic acidemia, neurological sequelae, and also pyramidal and extrapyramidal deficit which will cause intellectual disability and also developmental delay. So investigation is serum ammonia is elevated, and iron gap will be large. Plasma valine, isoleucine, and leucine will be decreased because of lack of this conversion. And then serum propionic acid and CT also, and or MRI is if it is indicated. And then management for acute is hydration, treat metabolic acidosis, and also ensure caloric adequate calorie intake. And for chronic management, long-term management, we can give L-carnitine supplementation, and also protein restriction. All right, that's all from me. Any question? So this one is on the example of inborn error metabolism request form. So we can send this form to biochemistry unit of KKM. So in this form, next, they contain of symptoms and also sign checklist. Next, okay, so this is PE that you have to do. Next, okay, so treatment given, and also special metabolic investigation that you want to request. Okay, that's all.
Okay, great. Okay, very detailed. Okay, it's good. So any questions? Dan IgE mediated cosmic protein allergic. Lepas tu multiple food allergic. Itu nombor 2. Okay, so ada questions? So can you summarize Najwa, siapa namanya? Fatimah.
Fatihah.
Fatihah. Okay, can you in one sentence or in one or two sentence, can you summarize what is IEM?
IEM is metabolic disorders that is we can prevent the fatality if we diagnose it early.
Does it has to be fatality? Is it all IEM fatal?
No, but we can prevent the it from being deterioration. We prevent from being deteriorated.
Do we actually need to treat all IEM? Do we need to treat all IEM? Is it all IEM will deteriorate?
No, because the presentation is different among the from each person. Even though the defect is we need.
What is IEM?
So inborn metabolism is a disorder at the metabolic pathway that we have to diagnose early and manage according to the condition of the patient.
Okay lah. Terima lah. Tapi tak apa-apa mark. Okay lah, in general. Okay, what is metabolism? What constitute metabolism? Apa dia metabolism ni tahu? You ada anabolism and metabolism kan?
Okay, so
what is anabolism? What is anabolism?
Anabolism.
What is anabolism?
Anabolism is the process when the body want to produce the energy.
Oh, mana pula? Yeah. Anyone what is anabolism? I just want to make it clear lah to you guys what is actually what we are talking about. You know, because a lot of people they don't actually understand what is IM. So if you don't understand, then you cannot identify them lah. Okay, so what is anabolism? Is there anyone? And what is catabolism? Anyone? Okay, so basically anabolism is a process, it's a metabolism process from a simple molecule to a complex molecule. Contoh anabolism is you campur glukos jadi apa? Sebab glukos campur glukos jadi apa? Alah, you guys ni. Come on, glukos campur glukos. You guys dengar tak?
Maltose ke?
Maltose kan. Okay, kalau galactose, so galactose campur dengan glukos jadi apa?
Lactose.
Galactose campur glukos jadi?
Lactose.
Lactose. Okay, these are anabolism. Okay. Okay, good. So these are anabolism. Anabolism means from simple molecule to a complex molecule. This is simplified lah. Then what is catabolism? Is the other way around. For example, you ada lactose, and with the presence of lactase, you convert it to galactose and glucose, and you can absorb. You can utilize the glucose and galactose, but you cannot utilize lactose. Faham tak? And this applied to all metabolism. Okay, to all metabolism. And each of this process require enzyme. Okay, lactose nak jadi simple sugar require enzyme. Simple sugar nak jadi complex sugar pun require enzyme. So in IEM, the problem is there's genetic defect in the gene coding the protein of this enzyme that leads to failure of metabolism. Faham tak? So what happens? So kalau you ada banyak sangat simple sugar, apa jadi ialah simple sugar ni tak boleh jadi complex sugar. So apa jadi? Dia dapat accumulation of toxic. Faham tak? Kalau you tak ada enzyme untuk convert all this complex compound to simple compound, you akan ada toxic accumulation juga, number one. And secondly is you akan fail to utilize the complex molecule. So for example macam galactosemia, GSD, glycogen storage disease. You ada a lot of glycogen yang tak boleh being converted into glycogen, you catabolize jadi apa? Glyceride kan? Okay, anyway, so tak apa saya cakap nak. So what happen is, you ada banyak sangat glycogen yang cannot be catabolized into simpler sugar or simple lipid that can actually be converted into energy or ATP. So what happen is, those with GSD, dia ada banyak sangat glycogen, so dia tak boleh store. So dia store kat liver dia jadi besar. Dia store dekat kidney jadi besar. On top of that, lepas tu dia boleh store kat spleen juga, spleen pun jadi besar. On top of that, dia tak boleh tu when they are fasting, when they need the energy, when they need the simple molecule untuk converted to energy for respiration, they don't have it. So dia dapat apa? Hypoglycemia. Dia dapat hyperlipidemia. Hypercholesterolemia. Bukan hyperlipidemia, dia dapat hypercholesterolemia. So cholesterol is a complex sugar, complex molecule, glycogen yang tak boleh converted. Faham tak? You guys understand kan? So this is IEM. Faham kan? You guys ni silent sangat lah, risau lah. Tak apalah, kita continue lah. Ada soalan? You dengar tak ke tak dengar? Dengar tak?
Dengar.
Dengar.
So you faham tak?
Faham
Ada soalan?
doktor.
Okay. One thing I always tell my student lah, even anyone lah, my MOs ke, even my specialist when I cakap juga. Basically the principle is, if you don't understand your physiology, then you won't be a good doctor. You need to understand your physiology to explain the pathology. Faham tak? Okay, so that's it lah, IM. So ada soalan? Oh, we are ahead of time. No, we are behind time. So ada soalan tak? Ada soalan tak?
Tak ada.
Kalau tak ada, then continue lah. Okay, continue the third presentation lah. This one make it quick, make it quick. Just each slide though, you spend at most 1 minute each slide, at most. I would expect
okay.
each slide sepatutnya 10 seconds je. Okay.
Okay, Bismillahirrahmanirrahim. Assalamualaikum. My name is Sabila. I am the last presenter for today. I will be presenting about sepsis and septic shock. Next. So these are my outline. I will be discussing on definition, pathophysiology, risk factor and causes, clinical features, investigation and management. Next. Okay, let us start with definition. These are 5 important terms that we need to understand. Infection, SIRS, sepsis, severe sepsis, and septic shock. Next. Okay, for infection, so what is infection? Infection is suspected or proven infection caused by any pathogen. So the definition also includes the clinical syndrome associated with a high probability of infection, such as petechiae and purpura in a child with hemodynamic instability, fever, cough, and hypoxemia in a patient with leukocytosis and pulmonary infiltrates on chest X-ray. The infection can be proven by positive culture, tissue stain, or PCR test. Next. Okay, systemic inflammatory response. So SIRS is a widespread inflammatory response that may or may not be associated with infection. So these are the criteria that we need to consider in SIRS, which consists of temperature, heart rate, respiratory rate, and leukocyte count. So SIRS is defined as presence of 2 or more of these criteria, which one of the criteria must be abnormal temperature or abnormal leukocyte count. Okay, next. Okay, this table shows the vital sign and lab values according to age that defines SIRS. You can read later. Next. Okay, sepsis. Sepsis is simple. It is SIRS in the presence of infection. SIRS plus infection is sepsis. Next. Okay, for severe sepsis is associated with, you can see in the table below, sepsis is associated with cardiovascular dysfunction or sepsis plus ARDS or sepsis plus 2 or more other organ dysfunction. Next. So this table shows the criteria for cardiovascular dysfunction, ARDS, and organ dysfunction. You can read later. Next. Okay, these are the details for criteria for organ dysfunction. I think you can read later. Okay, next. Okay, for septic shock, what is septic shock? Septic shock is severe sepsis plus the persistence of hypoperfusion or hypotension despite adequate fluid resuscitation, or the patient require vasoactive agents. So septic shock encompasses multiple forms of shock, which is hypovolemic shock, distributive shock, and cardiogenic shock. Next. So this is the summary. It starts with SIRS and then sepsis. Sepsis is SIRS plus infection. Severe sepsis is sepsis plus and organ damage. And then septic shock, which is severe sepsis plus persistent hypotension or hypoperfusion. Okay, next. Okay, for the pathophysiology, sepsis occurs when the release of pro-inflammatory mediators in response to an infection exceeds the boundaries of the local environment, leading to more generalized response. The reason for this is uncertain. However, the cause is likely multifactorial as listed in the table. The first one is due to effect of microorganism, whereby the microorganism will release the toxin in the bloodstream that will produce many of the features of sepsis, including activation of the complement, activation of the coagulation, and fibrinolytic system. And this will lead to microvascular thrombosis and the production of vasoactive products. Okay, the second one is excess pro-inflammatory mediators, whereby the large quantities of pro-inflammatory cytokines released in the patient may spill into the bloodstream and contributing to the progression of a local infection to sepsis. These include TNF-alpha and interleukin-1, and both cytokines can cause fever, hypotension, leukocytosis, and it will also induce other pro-inflammatory cytokines and stimulate the activation of the coagulation and fibrinolysis. Okay, the last one is complement activation. There is evidence that activation of the complement system plays an important role in the sepsis. Okay, next. I've mentioned just now, the activation of the complement system, activation of coagulation system, and release of the mediators will lead to systemic effects such as hypovolemia, cardiac and vascular failure, capillary leak or endothelial damage, ARDS, DIC, and decrease in steroid synthesis that will progress to shock, MODS, and it will lead to death. Next, okay, we proceed to risk factor and causes. Now, next. Okay, the following factors have been associated with an increased risk of septic shock. The first one is age, less than 1 month, serious injuries such as major trauma and burns, chronic medical conditions such as congenital heart disease, host immunoresponse, for example, HIV infection and severe malnutrition, large surgical incision, catheter or invasive device such as endotracheal tube or chest tube, and urinary tract abnormalities with frequent infection. Next, for the causes, of course, the causes of septic shock and sepsis is due to infection. So these are the etiologies. It can be due to bacterial infection, viral infection, and other infections such as fungal, parasitic, rickettsia, and rickettsia. For fungal, it is only exists in 10% of cases and is more common in children with certain risk factors such as immunocompromised medical condition. You can read later. Next. Okay, for clinical features, the children will be presented with symptoms and signs of infection, sepsis, and septic shock. So let us go by one by one. Next. Okay. First is infection. For infection, the clinical features depends on the site of infection. For example, if the site of infection is at the lower respiratory tract, so the patient will have productive cough and also pleuritic chest pain. If the infection is at the upper respiratory tract, the patient will present with pharyngeal inflammation and exudate, swelling, and also lymphadenopathy. So the other infection you can read by yourself. Next. Okay, the patient also will be presented with clinical features of sepsis. From history, the parents will be complaining of their child having fever, poor feeding, miserable, irritable, lethargic, history of focal infection. I had explained just now. And the patient also might have predisposing conditions such as sickle cell disease and immunodeficiency, which will increase the risk of sepsis. So for physical examination, the patient will have toxic or ill appearance, sign of dehydration, altered mental status, fever, tachycardia, tachypnea, or low blood pressure, purpuric rash, which suggests meningococcal septicemia, shock and multi-organ failure. So the picture on your right side shows the glass test for meningococcal purpura that does not blanch when pressed under a glass. If the child is febrile and has this type of rash, we can suspect that the patient is having meningococcal disease. Next. The clinical findings of shock vary depending whether the patient has warm or cold shock. Warm shock will be presented at early stage, followed by cold shock at later stage. So warm shock is distributive shock characterized by hyperdynamic or high output state with decreased systemic vascular resistance and elevated cardiac output. The clinical findings are listed in the table on your right side, where the patient will have warm and flush peripheries, capillary refill time of less than 2 seconds, bonding pulse, tachycardia, BP is maintained, and widened pulse pressure. For cold shock, it is a hypodynamic stage which reflects increase in systemic vascular resistance and decrease in cardiac output. The clinical features of cold shock includes cold peripheries, delayed capillary refill, which is more than 2 seconds, weak pulse, heart rate can be tachycardia or bradycardia, hypotension, and narrowed pulse pressure. Next. Okay, so for investigation, actually, sepsis and septic shock is actually diagnosed based on history and physical examination. However, investigation may be helpful to look for evidence of hematology abnormalities and electrolyte disturbance, and it also investigation also can help us to find the source of infection. So for bedside, uh, first is we can do capillary blood glucose. So the patient will have hyper or hypoglycemia due to stress response to shock. Next is pulse oximetry, whereby the SpO2 will be decreased due to hypoxemia. Next, for lab investigation, we can send for, as usual, we send for full blood count. So there will be leukocytosis, which indicates infection, and thrombocytopenia due to hematologic abnormalities. Next, arterial or venous blood glucose to look for metabolic acidosis. Serum lactate will be increased, which suggests lactic acidosis due to tissue hypoperfusion. Serum electrolyte will show electrolyte imbalance, electrolyte disturbance. Blood urea nitrogen and serum creatinine. For BUN, it will increase, which indicates dehydration, while elevation in creatinine will indicate renal dysfunction. So next is serum calcium to look for hypocalcemia. Next. Okay, next is liver function test. There will be increase in AST and total bilirubin, which indicates liver dysfunction in the setting of sepsis. Next, coagulation profile. There will be increase in PT and APTT or INR, which suggests DIC. Fibrinogen and D-dimer. Fibrinogen will be decreased and D-dimer will be increased, which indicates consumptive coagulopathy and DIC. For blood culture is important. It should be obtained in all patients before antibiotics are administered to determine the specific organism. Urinalysis indicates the presence of bacteria, nitrate, or pyuria, which indicates UTI. And we can also do urine culture to find evidence of UTI. Other culture also should be obtained, such as CSF, wound culture, aspirated fluid, and fungal or viral culture should be obtained as indicated by our clinical findings. Okay. The last one is viral culture and PCR for viral infection. Okay, next. Okay, for imaging, we can do chest X-ray to rule out pneumonia, pulmonary edema, and cardiac failure. Also, we can do CT scan of the brain, which might suggest intracranial hemorrhage, CT abdomen for abdominal abscess, and we can do ultrasound abdomen to look for abdominal abscess. Okay, next. Okay, for management, early management is in sepsis and septic shock. Early management and early intervention is extremely important to prevent mortality. So for management, we can divide into 3, which is initial management, further management, and supportive management. Next. Okay, for initial management, it includes respiratory support where we give the patient oxygen, and then we secure intravenous or intraosseous access, and we perform blood investigation. Investigation includes blood culture and ABG, and then fluid resuscitation, empirical antibiotics, and administration of inotropes or vasopressor. So all of this must be performed as soon as possible and within 1 hour of diagnosis. Okay, you can see see the timeline on your right side later. Okay, next. Okay. For respiratory support, it depends on conscious level of the patient. If the patient is normal, is conscious, so we give non-invasive ventilation. If the patient is unconscious, we consider intubation. For fluid resuscitation, we give 20 milligram per kilogram crystalloid over 5 to 10 minutes. The maximum is 40 milligram per kilogram. The alternative fluid is Hartmann's or Ringer's lactate. Fluid resuscitation is important to reverse hypotension, increase urine output, attain normal capillary refill, peripheral pulses, and normal level of consciousness. Okay, for empirical antibiotics, antibiotics must be administered as soon as possible and within 1 hour. For age less than 3 months, we will administer cefotaxime and C-penicillin. And for age more than 3 months, we give ceftriaxone and cefotaxime. Okay, next is inotropes or vasopressor. It is considered in children who are not responsive to fluid resuscitation, whereby the patient will still have persistent shock after 40 milligram per kg of fluid, after 40 milligram. Okay, so the agents include adrenaline, noradrenaline, dopamine, and dobutamine. And we can consider vasopressin if patient is not respond to noradrenaline or adrenaline. Okay, next. Okay, these are the effect of inotrope. You can read later. Next. Okay, for further management, we need to monitor the lactate level because the lactate level is used as a surrogate for tissue hypoperfusion, meaning that it represents the severity of the tissue hypoperfusion, and so it is useful to guide for resuscitation. Next is second line vasopressor to improve blood pressure. We also need to maintain blood glucose between 4 to 8 millimole per liter. Titration of fluid and inotrope to optimize vital signs, urine output, and conscious level. And we can also perform echocardiography to determine fluid status and cardiac function. Next. Okay, so the goal of resuscitation is to normalize the vital sign, where we aim for a normal blood pressure and a normal pulse rate. For clinically, we aim for normal capillary refill, warm extremities, normal urine output more than 1 milliliter per kilogram per hour, and normal serum lactate and mental status. So these are our aims. You can read on the table later. Okay, next. For supportive management, we give steroid, IVIG, venous thromboembolism prophylaxis, PET cell transfusion, renal replacement therapy, stress ulcer prophylaxis, enteral nutrition, and family coherence. You can read the detail later. Okay, next. That's all from me. Thank you.
I have a question. Hello, can you hear me? Why do we need to assess clinically and differentiate between warm and cold shock? Is there any differences in terms of maybe specific management we give?
Based on what I have read, the warm shock is compensated shock, whereby it will present in early stage, but for cold shock, it will be presented in later stage, whereby it is decompensated. For warm, we can still treat compensated, but for cold shock, it is decompensated.
Hello, I have a question too regarding
Okay.
the definition of sepsis. I think there is no more SIRS and severe sepsis, if I'm not mistaken. So we only have
based
ke?
on what I have read in up to date, we still use the terms in PACE. Yang berubah, yang kita guna yang apa tadi?
Kita guna sepsis dengan septic shock.
Yang tu for adult je.
Oh, okay.
Kalau
Thank
for
you.
PACE dia guna yang ni.
Alright, thank you.
Okay.
Sorry. Saya tak dapat ada orang datang cakap kat sini. Apa soalan tadi? Term apa? Yang kata adult guna tu?
Adult tak guna apa? Tak guna severe sepsis.
Tak guna severe sepsis dengan SIRS.
Oh, SIRS memang dah jauh dah zaman kaduk lah. So dia guna apa? Dia guna shock dengan?
Dia guna sepsis dengan septic shock only.
Actually SIRS pun kita tak guna sangat in pediatric. But SIRS is very important lah, especially in viral punya infection. And actually kan, tu lah, ini baik komen lah. Tapi kan, a good seminar kan is you give us something yang up to date, rather than something yang, of course these are, I think your presentation ni okay lah. Saya ikut guna up to date tu should be up to date lah, as the name mention kan. Tapi you know things like new things macam COVID kan. COVID is very relevant to us tau. Especially we know COVID is the pathology of COVID and the effect of COVID is actually due to dia punya SIRS. It's not because of infection. In fact, you should give like example kan. Contoh SIRS. Okay, what are examples of disease yang SIRS tu is actually causing us the problem? It's not the infection. For example macam dengue. Dengue kan. Problem with dengue is not the infection or it's not the infection. It's actually the SIRS. Tahu tak? Orang mati because of the SIRS in dengue. Capillary leakage because of the inflammatory response. Or the interleukins, cytokines, or the apa tu? You punya mast cell, punya neutrophil punya activation. Faham tak? In fact, a lot of contoh macam hepatitis B, hepatitis C kan. The condition, especially hepatitis B lah. The problem is not with the virus. The problem is you punya immune system. Faham tak? The immune response kills you. That's why a lot of condition kan, yang inflammatory condition macam ni kan, SIRS ni, the treatment is actually with steroid. Tapi kalau you ada infection with bacteria macam tu, you buy steroid, matilah patient. Faham tak? Because if the direct effect of the complication is caused by the organism itself, by the microbes itself, then you need to kill the microbes. But a lot of condition, infection condition, the complication also, the effect, the lethal effect is caused by your immune system. So the treatment is actually immunosuppression. Kalau you tengok treatment COVID, kan, mana ada orang talk, we rarely talk about viral punya antiviral. Adalah lopinavir, kan, Kaletra ataupun remdesivir kan. Tapi most of the treatment we are focused on the immunomodulation kan. Hydroxychloroquine, dexamethasone, because we know the effect is actually because of your immune system. So by dampening your immune system, you prevent the complication of COVID. Faham tak? Sama je macam Hep C, Hep B, you give interferon, you give nucleoside analog. These are not to kill the virus. This is actually to kill your immune system, your local immune system. Faham tak? Okay, that's why a good practice is when you start an antibiotic, especially broad spectrum antibiotic ataupun bactericidal antibiotic, you have to observe the patient because patient can die because of the antibiotic. for example kan, if you ada infection, E. coli contoh, you ada E. coli kan, endotoxin producing E. coli for example. Okay, and then you ada shock, you ada systemic infection, you may sepsis lah because of E. coli. The problem with some organism, if you give them very potent, broad spectrum, very potent bactericidal antibiotic, this antibiotic will cause, most antibiotic they works dekat mana? Most bactericidal antibiotic they works dekat mana? You guys dengar tak? Exam ni aduh. Hello?
Dengar doktor.
Saya jawab Takkan tak ada orang jawab. You guys are 5th year. Lah quarter year tu memanglah selalu diorang senyap lah.
Cell wall.
Selalu bactericidal antibiotic. Contoh apa? What is contoh of bactericidal antibiotic yang you tahu? Macam what? You mention tadi. Actually almost all yang you mention tu semua bactericidal antibiotic. So it's cephalosporin, kan, penicillin. So dekat mana yang bactericidal antibiotic ni works? Dia punya target
Cell
kat
wall.
mana? Cell wall, okay good kan, cell wall. So apa jadi bila you target cell wall? You pecah cell wall, so apa jadi?
Bacteria lyse.
Macam mana bakteria boleh lyse? Kenapa bila ada cell wall dia tak lyse? You belajar tak waktu sekolah rendah kan? Yang sel animal dengan sel human. What is the apa yang jadi?
Maintain rigidity.
The integrity and rigidity of your membrane kan. You have to remember you punya plasma ni is isotonic to your cell, tapi it may not be isotonic to other cell, especially microbes. Okay, most of the time is isotonic because these are unicellular organism tau. Most of them are unicellular organism yang semua metabolism occur in the cytoplasm. So they are very plasma rich, very protein rich cytoplasm in the organism ni. So kalau you masuk dekat relatively hypotonic solution, which is your plasma kan, apa jadi kat diorang? Kalau dia tak ada cell wall. Kerja osmosis kan? Osmosis lah, dia kerja osmosis. Faham? So water from your plasma masuk dalam sel dia akan lysis. Kan? Dia akan pecah lah, dia mati. So bila dia pecah, dia release all this endotoxin yang ada dalam badan dia tu. And this what called inflammatory response. What we call exaggerated inflammatory response. Macam ni yang jadi dekat COVID, ni yang jadi dekat dengue. Faham tak? This leads to vasodilatation, exudation formation, exudation, inflammation dekat lung. Just imagine lah kalau you ada that organism dekat lung. And then this organism inflammatory response, you punya you punya innate immune response kan, dia recruit all these cytokines, all these interleukins pergi dekat lung attack. So this will damage the lung. This what called the ARDS in COVID. Faham tak? And this what called the capillary leakage in dengue. Faham? So that's why bila you bagi a broad spectrum antibiotic, especially bila you tahu patient memang ada organism kan, atau memang highly suspicious of sepsis, you kena observe because they can get into shock. Okay, faham tak? Faham tak?
Faham.
Okay. Okay, you guys cakap lah. Saya tak nampak you guys. So, and you guys pun tak nampak I. So, you guys kena cakap baru I tahu you tak tidur. Okay lah. So, ada soalan last? Okay. Okay lah. Kita tangguh dengan tasbih kafarah. Dan suratul as. Okay, assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Doktor.
Thank you, Doktor.
Edwin, nanti share me your slides
Okay.
WhatsApp ke? Okay, thanks.
Okay.